Hi, this is Dr. Fox, and let's talk about fascia. In this video, we'll discuss the fasciae associated with the neck, the various layers and distribution of the deep cervical fascia, and the boundaries and divisions of the retropharyngeal space. First of all, what is fascia? And how do you say fascia? Fascia, fascia, fascia. There are a number of ways you can pronounce it. For this guy from the foothills of the Appalachian Mountains in western Pennsylvania, I pronounce it fascia. So, fascia is the connective tissue found deep to the skin and in deeper regions. It's basically collections of connective tissue. So for your reference, in the laboratory, we will be skinning donors, and skinning involves removing the epidermis and the dermis, which together comprise the skin. Deep to the skin, we have the superficial fascia, also known as the subcutaneous layer or just the sub-Q for short. This is a collection of loose connective tissues, such as adipose connective tissue and areolar connective tissue. Deep to that superficial fascia is the deep fascia and muscular layers, and that deep fascia is going to envelop the various deeper muscles as we go. So, epidermis is the most superficial tissue layer. That is an avascular layer. The dermis is the deeper part of the skin. Then we have the superficial fascia, or the sub-Q, and then we have the deep fascia and the muscles. And that deep fascia will be layered, as we'll see. So within the neck, we have the deep fascia in 3 separate layers. These fascial layers include the investing fascia, the middle fascia, and the deep fascia. Understanding fascial layers is important because these represent potential cleavage planes for performing procedures. They also represent potential routes that infections may take as they traverse various regions of the body. And as we dissect, when you find fascial planes, it becomes very easy to separate the layers because those fascial planes are very loosely associated with one another. So let's start with the most superficial layer of the deep cervical fascia, the investing fascia. The investing fascia is sometimes referred to as the superficial layer of the deep cervical fascia, but sometimes it's confusing to call it that because we would have the superficial fascia just above it. So superficial fascia, then superficial layer of deep cervical fascia. You can also refer to it as the epimysium of the sternocleidomastoid muscles, which we can see there and there. So this is anterior, by the way. This is posterior. And we can see how that investing fascia of the deep cervical layer also invests or surrounds the trapezius muscles as well. So that investing fascia goes all the way around the entirety of the neck. But keep in mind that it's investing both SCM and trapezius muscles. Now, as we move deeper, we come across the middle or the pretracheal layer of the deep cervical fascia. This layer of fascia is exceedingly thin and found only anteriorly. And so it's going to have 2 distinct components to it. There's going to be a muscular part. The muscular part is what invests the infrahyoid muscles, as we can see here, as well as a visceral part that's going to invest the thyroid gland, which we can see here, the trachea, and part of the esophagus as well. And then posteriorly, we have that visceral layer meeting up with and being contiguous with the buccopharyngeal fascia of the pharynx. That buccopharyngeal fascia can be conceived as the posterior aspect of that visceral layer that's going to descend the pharynx or the throat from the skull all the way down along that alimentary canal, so that's along this region, down to the fibrous pericardium of the heart within the thorax. So when we talk about the movement of infections, in particular when we think of infections of the oral cavity, so odontogenic infections moving from the oral cavity, these can eventually find their way down to the heart by means of following fascial spaces along the way. So as we go even deeper, we come to the third and final layer, the deep layer of the deep cervical fascia. And there are two particular layers to this. Anteriorly, there is the alar fascia. Alar means wing, and so it's going from the wing of the vertebrae all the way across to the other. And then we have the prevertebral layer of the deep layer, which is investing all about the deep neck muscles, things like those scalene muscles, etc., all around the vertebral column and in front of the vertebrae itself. That's why we call it the prevertebral layer, even though it invests all the way around the vertebrae. And so what we have here are layers of fascia that are sandwiched upon one another that have potential spaces between them, as we'll see. And we're going to eventually focus on these spaces here, which we'll get to in a moment. But before we do, let's discuss the carotid sheaths. Now, there is very little agreement amongst sources as to where the entirety of the sheath comes from. It's best probably stated that the carotid sheath is the fascia surrounding the common carotid artery, the proximal internal carotid artery, the internal jugular vein, as well as the vagus nerve. We can see that these carotid sheaths are found laterally within the neck, and the contents have a very specific anatomical relationship to one another that we should try our best to understand now because it will inform our progress in lab. So medially is the common carotid artery, and as we ascend the neck, the internal carotid artery. Laterally is the IJV, the internal jugular vein. And then posterior and intermediate between the two is the vagus nerve. We can also find within the sheath deep cervical lymph nodes and the jugular lymphatic trunk. Those are typically associated with the internal jugular vein. And just posterior-medial to the sheath, I'll point these out right there and there. Those are the cervical sympathetic trunks. Sometimes the ansa cervicalis can be found embedded in the carotid sheath. So some people consider ansa cervicalis of the cervical plexus, that meshwork of nerve that innervates the infrahyoid muscles, to be part of the contents, but generally we exclude it as carotid sheath contents. Get along. Let's talk about the retropharyngeal space and the subdivisions of the retropharyngeal space and their significance. So we already discussed that fascial planes represent opportunities for surgeons to separate tissues. They also represent opportunities for materials to move throughout the body. So we can think of this in several ways. So metastatic illnesses like certain cancers can spread throughout the body through these fascial spaces. Various infections can spread throughout the body. Anesthetic agents can spread throughout the body. Even air or other substances, such as anesthetics, can spread throughout the body in traveling along these planes. So it's important that we understand them. And one of the most important fascial spaces within the neck, and certainly the one that's the most clinically germane to the study of dentistry, is the retropharyngeal space. So the retropharyngeal space is going to be the space that anteriorly is bounded by the buccopharyngeal fascia and posteriorly by the prevertebral fascia. Now, as you can see, there's going to be a layer of fascia between those two called the alar fascia. That alar fascia is contiguous from the base of the skull, so the first cervical vertebrae, down to, and this is variable, the sixth cervical vertebrae to the fourth thoracic vertebrae. And what happens is that alar fascia is going to, at some level, fuse with the buccopharyngeal fascia anteriorly to create a pocket. And so we would refer to that space between the buccopharyngeal fascia and the alar fascia as the true retropharyngeal space, which would be the anterior portion of just the retropharyngeal space. The space between the alar fascia and the prevertebral fascia is what we would call the danger space, because this is the space that would connect the oral cavity eventually with the thoracic cavity. Let's look at this in profile to have kind of a better understanding. So the most superior aspect of the pharynx is a muscle called the superior pharyngeal constrictor muscle. And it is invested anteriorly by the pharyngobasilar fascia and posteriorly by that buccopharyngeal fascia. So that buccopharyngeal fascia goes from the base of the skull all the way down to the thorax. Now, as we move all the way posteriorly, we have that prevertebral fascia. The prevertebral fascia also goes from the base of the skull all the way down to the thorax. And so in total, all of that is called the retropharyngeal space. But we know that it's divided by that alar fascia. The alar fascia goes from the skull base, so from about the first cervical vertebrae, all the way down to somewhere between the sixth cervical vertebrae and the fourth thoracic vertebrae. And so that is going to then attach to the buccopharyngeal fascia to form kind of a pocket. That space is the true retropharyngeal space, whereas the space posterior to the alar fascia and anterior to the prevertebral fascia is known as the danger space. And it's called the danger space because that's the pathway through which infections can move from the oral cavity and regions lateral down to the heart. So that leads us to our assessment question of the video, and that is, an infection originating from a periapical abscess of a mandibular second molar could theoretically travel to the thorax via which conduit? Is it the danger space, the true retropharyngeal space, or the retropharyngeal space? Well, retropharyngeal space is going to include both A and B, so that's probably not the correct answer. We know that the true retropharyngeal space is that space anterior between the buccopharyngeal fascia and the alar fascia, and we know that this peters out somewhere between C6 to T4. So that can't be the possible answer, and that leaves us the danger space. And, an infection traveling between the oral cavity and the heart would be rather dangerous, and so calling it the danger space makes sense. Therefore, A is the correct answer. Thank you so much for your time.